Welcome to the DeSales Scholars Series, COVID-19 and the Vaccines, an update. Before I introduce our distinguished panel today, I would like to remind all of you joining us here in person and at home to hold your questions till after the presentation. If you are joining us on Zoom, please use the chat box. As we get started, I would like to introduce our presenters. Back from our first episode of the coronavirus and the vaccine, we have Dr. Beachboard. She is an assistant professor of biology at DeSales University. She teaches courses in microbiology, immunology, and virology. Dr. Beachboard has been studying coronaviruses since 2008 and is interested in host-pathogen interactions between coronaviruses and the host cell. Her research is currently focused on understanding how coronaviruses evade the host innate immune response. Dr. Beachboard has published peer-reviewed articles in bacteriology, coronavirus genetics, and cell biology, and innate immunity to RNA viruses, including the Zika virus. Joining Dr. Beachboard today, we have Dr. Joshua Slee. He is an assistant professor of biology, the division head of sciences and mathematics, and the department chair of biology at DeSales University. He has taught courses in cell biology, cell culture, genetics ethics, microbiology, and immunology. Dr. Slee's research focuses on understanding the innate immune response, the involvement of the inflammatory response in various diseases, and finding creative ways to attenuate inflammation associated with medical issues. He has published peer-reviewed publications in the areas of exercise-induced asthma, cardiovascular disease, heparin signaling, and biomaterial rejection. And today, our hosts are joined by a very special guest. Faith Colen is a 2002 graduate of DeSales University with a bachelor's in science of nursing and a 2008 graduate of Indiana University of Pennsylvania with a master's in nursing education. Faith has worked at UPMC in Pittsburgh for 20 years in various roles of nursing, primary and emergency nursing, and is certified as an emergency nurse. Most recently, Faith's career has led her to the Director of Quality and Patient Safety at UPMC's St. Margaret. In this role, Faith serves as a patient safety officer, compliance officer, and a privacy officer with the oversight of patient safety, hospital quality performance, risk management, infection prevention, regulatory, stroke and orthopedic programs, care management, and social work. Faith is also a certified as a professional in healthcare quality and a board certified nurse executive. Faith is a national and international speaker on topics of emergency nursing, quality, safety, and patient advocacy. Over the past 18 months, Faith has helped lead UPMC's St. Margaret's pandemic response to COVID-19 and was honored to be on the panel for the Hospital and Healthcare Association of Pennsylvania's 2020 Patient Safety Quality Symposium, Facing the Enemy, Experiences of Being a Frontline Provider During COVID-19. So with these introductions, I would like to welcome our panelists, and I'm going to start with Dr. Joshua Slee.
Thank you for the introduction. You got to deal with me first. We're going to save the two superstar ladies for last, okay? All right, so why are we here today? So Advancement asked us to come back and give an update. I think it's an important time right now. You've probably heard there's a lot of news coming out about boosters and third shots. And do I need a second shot if I have the J&J shot? So really, what we're hoping to do is just kind of give you a data-informed presentation about where we are, where we think it's going, and some practical advice on what you can do, okay? So that's what we're here for today. So first, we're gonna break it up into a couple areas. The first, we're gonna look at the vaccines and unfortunately, cases and deaths, okay? So the first thing to point out is how are we doing as a nation in terms of our vaccination rate? Short answer, not very well, okay? So the greener the left side is, the darker it is, the more percentage of the population of that state is vaccinated, right? So we want to see lots of dark green. However, we see more shades of light green, indicating that less than 50% of the population in that state is fully vaccinated, right? If we look at it by age range, on the right-hand side, see if I can close this without wrecking everything. If we look at the right-hand side, we can break it up by age instead of by state. Okay? We're doing fairly well in terms of the older population. I would like to see it in the 90 percentile range. Again, 75 plus, 65 plus, we're heavily vaccinating in that area. And that's a good thing. By and large, they are the most at risk for complications and death due to COVID-19. Where we start to fade off, though, is as we get younger and younger and younger. Where we're really not doing well is that 12 to 24 range. All right. And I think there might be some hesitancy among that group because they're probably the safest when it comes to complications and death due to COVID-19. All right, so the incentive to get vaccinated isn't as urgent for them as it is for somebody who's 55, 65 plus. However, I think we need to promote vaccination in that group. And I think the most alarming statistic, usually I think the number that's thrown around is about 66% vaccinated nationwide. That puts us at number 48 in the world in terms of vaccination. And that's despite the fact that the United States is the leader in the science and the production of the vaccines. So we're the best at making it, we're the best at the science, we're number 48 in terms of how many of our population are vaccinated. I think we can do better, all right? And again, I don't mean to make anything political, and I don't mean to be political, but I think COVID has become political, all right? So what we're looking at here is that same graph of vaccination percentage. And on the right, we have states that are predominantly Democrat or predominantly Republican. And I think it's pretty clear which states are lagging behind in terms of their vaccination rate. And healthcare should never be a political decision, it's a human decision. So I think we have to kind of take the politicalization out of it and look at it as a human issue and as a healthcare issue, all right? The other interesting thing that vaccination of adults correlates with is school closures in K to 12. All right, so if you look at the areas where we have lower vaccination rates, generally we see higher incidences of school closures due to COVID-19 outbreaks. All right, so until the FDA and the CDC approve vaccines for young children, the best thing we can do to protect them is vaccinate more adults. All right, it creates a bubble around the children and keeps them safer. The good news is it looks like the FDA is going to approve shots for children down to 5 within the coming weeks. Right. When we look at reasons why individuals would opt to get a vaccine after June of this year, okay, so we're getting rid of the people that got on it right away. All right, 3 or 4 things rise to the top. Okay, the first, people are afraid of Delta. Delta is a highly infectious, very easily spread variant of COVID. All right, so 39% of people said that was the major reason why they decided to get vaccinated. Just underneath that is witnessing what's going on in the hospitals. And that's why we're excited to have Faith with us today, because she can really testify to what's happening on the front lines. All right, when you see ICUs being filled up as a result of COVID, that has sparked people to get vaccinated. 36%, unfortunately, it's the saddest case. They witnessed somebody get ill or die because of COVID. I would hope that we don't have to see somebody die or get significantly ill in order to go out and get a vaccine. But 36% of the people said that's why they did. And then 35% basically said there was an activity that I wanted to do that required me to get vaccinated. So maybe it was go to a concert, go to a gym, go on a cruise, whatever it might be. So many of us probably don't agree with mandates, but it does seem to increase vaccination. One of the other areas I think that's important to point out as part of our Salesian mission here at DeSales is if we look at who's not getting vaccinated in terms of demographics, and I've put 4 asterisks up there because I think there's 4 worth talking about. The 2 biggest ones, in my opinion, the people that aren't getting vaccinated the most for various reasons or don't plan to get vaccinated are the uninsured and those living in poverty. And I think that's really unfortunate because many of those individuals are probably most at risk of getting infected. Because generally they're the ones that are working multiple jobs, working in public-facing jobs, and they don't have health care. So it's the worst case scenario for those individuals because they're not vaccinated, nor do they plan on getting vaccinated. Okay? The other 2 areas where, again, we're not doing well, the 18 to 29-year-old population, so our college-age population. Again, I just don't think there's the motivation there because generally speaking, you're going to be okay. And then also in rural areas. So we see that the more rural the area is, the less access to vaccine, the less likely to vaccinate. And that can be seen with what's going on in Alaska right now. Alaska is experiencing extremely high case rates. And then this is hot off the press data that we finally have. Okay, so the one thing you have to remember with this is we're always a couple months behind with our data. All right, so there's a reporting lag. So all the data that we have now is current until the beginning of September. All right, and what we started to do now is we're finally tracking cases and deaths and correlating it with vaccination status, but also the vaccine that you received. And I think that's important. So here we're looking at just the number of cases, all right? And I think you can see just by looking at it, if you're unvaccinated, you have a significantly higher chance of catching COVID than you do if you're vaccinated, regardless of which vaccine you receive. Turns out to be about 6 times more likely, okay? Now, if we look at the vaccine types, I think most people would have guessed that this would have been the case, right? The Johnson & Johnson or the Janssen shot is slightly less effective than the Pfizer shot, which is slightly less effective than the Moderna shot. So we see more breakthrough cases in those that receive the J&J shot, and we see more in Pfizer, and we see less in Pfizer, and then we see less in Moderna, right? So again, suggesting that it is person-to-person variability here in how your immune system responds, but generally speaking, Moderna seems to be offering the best protection, followed by Pfizer, followed by Johnson & Johnson. And I think this data here was really critical in the discussion around whether or not we need boosters, right? Because what we're seeing now is we're seeing that our immunity is starting to wane a little bit for those that got vaccinated early on. All right, so the idea now is that maybe we need a third booster in order to further protect us from Delta. Okay. No surprise, it also correlates with death as well. So now this is the same graph, but looking at the number of deaths. And now you are 11 times more likely of dying from COVID if you're unvaccinated versus vaccinated. And again, we see the same trend in terms of the vaccine type, right? And I also think this might be part of the reason why we will start to offer mixed boosters as well. All right, so the FDA is set to overview it this week, and the CDC probably next week, maybe Friday, where if you receive the J&J shot first, you will be allowed to go back and get a booster of Moderna or Pfizer. All right. If you're somebody who received Moderna or Pfizer, it's probably best to stick with Moderna or Pfizer based on the data that we have so far. Okay. The other question that often comes up with the vaccine is, what's more likely to cause harm to me? Is it the vaccine or is it COVID? So this is a study that was published in the New England Journal of Medicine looking specifically at the Pfizer shot. And we're just comparing the number of excess cases per 100,000 of the population. That's basically a way of looking at it is, how many more cases than chance per 100,000 do we have? All right, so if we look at myocarditis, that's the one that's all over the news, that's heart inflammation. Vaccine, 3 per 100,000. COVID infection, 11 per 100,000. It's a pretty significant difference. The other risk, side effect, we'll call it, of the shot, enlarged lymph nodes. How many of you have been sick in the past and noticed lumps in your throat or in your armpits? That's your immune system working. So when you get a shot and you get enlarged lymph nodes, that's telling you that your body's doing what it's supposed to do. So many people view that as a good sign. Okay. We did see 5 cases of appendicitis and 45 cases per 100,000 of shingles. Anytime the body is stressed, shingles can reemerge. So shingles is the chickenpox virus that is dormant in your body and can become active again later in life. So if you're unfortunate enough, like me, to not have the chickenpox vaccine, shingles is probably in your future at some point. Okay. And then comparing that to COVID-19, we can see kidney failure, deep vein thrombosis, pulmonary embolism, brain bleeds, heart attacks, pericarditis, lots of really nasty things that you probably don't want that can be avoided by getting the vaccine. I'm going to pass it over to Dr. Beachboard, who is going to talk about masking and a couple other things related to where we're at.
Okay, as I start to talk about masks at the beginning of my classes, I often remind people to pull up their masks, and I'm looking around and I see no noses, so that makes me very, very happy. As lovely as people's noses are, I do not want to see them. So, thank you everyone for properly wearing your mask. Okay, so just have to get used to the floor right here. I thought I was stepping on something. What I'm going to talk about first is masking and the effectiveness of masking. So for this, we wanted to show in the pediatric populations because the pediatric populations are not vaccinated. So if we look at our unvaccinated population, are masks effective? Okay. Does this work? Okay. So if we look at this graph up here, we have weeks before school started, and we have pretty low rates of COVID. Okay, so we're not getting a lot of cases because nobody's actually at school. So what I want to focus on is this part of the graph over here once school has started. So in our dark blue is going to be our school or our counties that don't require masks, and then in light blue is our counties that require masks. And this was counties they took across the country. This was not isolated to any particular state, so you can't just say, no, that state just isn't good at it or whatever. This is the data across the United States. And what's pretty obvious is all those dark blue bars are way higher than the light blue bars. So the people who are masking have decreased rates of COVID. That should not be surprising. We've been dealing with this for 18 months, and we've always seen decreased rates when people are properly masked. So it's really, really important that we maintain these masks. And I do think that, at least I know some of our faculty members that I've talked to that have children, when the school year started, there was all these debates with the school board, masks required, masks not required. This data clearly shows that our children should be masking at school. Okay. And also, even as adults, we want to stay masked because those children can't be vaccinated. And the last thing we want is to be exposed to COVID ourselves and take that home to the children. Okay. So overall, this is just a graphic from the CDC. So schools without mask requirements versus schools with requirements, you are 3.5 times more likely to have COVID outbreaks if you are unmasked at your school. So again, this is highlighting that we should have masks and we should be wearing them properly. That means cover your nose too. Sorry, I feel like I'm preaching to people who are doing it properly in this room, but there are other people out there. There's probably people out in the hallway. Hopefully they can hear me and they pull their masks up. Sorry, that's something I deal with every day out in the hallways. Okay. So in terms of masking, so are masks kind of the be all and end all? No, this isn't the first SARS where it genuinely was the be all and end all, and that's how SARS-1 was halted in 2003, was through masks. However, we are using multiple layers. So this is the Swiss cheese model of protection, where each of these layers is going to have holes in it. But if you start kind of with just physical distancing and staying home when you're sick, what are the holes in that model? You can be symptomatic without being, or you can be asymptomatic and spreading virus. So not everybody is symptomatic, right? So you get some transmission pass through. So whenever we add in masks, people aren't always masked, they don't always have their mask on properly, so some gets through. We have hand hygiene and cough etiquette. So we're hand sanitizing, We're hopefully keeping our coughs and our masks, and if not, into your elbow, not into your hand, because then you touch everything and spread it everywhere. We're going to avoid touching our face. This one is honestly the hardest one for me. But you know, we're going to avoid touching our face so we don't transmit from objects to ourselves. Limit your time in crowds. So the more people together, the more disease spreads. That is true not just for COVID, but it's also been very prevalent in different outbreaks that prisons, college campuses, and things like that, where you have lots of people gathered together all the time living in a community, that you have increased spread of disease. Then we're going to add in testing, ventilations and air filtration, quarantine and isolation, all these different things, until we finally get to vaccines, which is going to kind of have the least amount of holes in it. But like Dr. Slee just mentioned, there are breakthrough cases with these vaccines, so nothing's perfect. So we have to mash all those things together and hope that none of those holes align with each other to let it through, right? Okay, so I hope I've illustrated that masking is really important. So for the next section, we're going to talk about the future. We're going to talk about variants. We're going to talk about whether we think this is going to be seasonal. And then we have a little bit of good news at the end. Okay, so for variants, you may even be wondering, what is a variant? So I'm going to equate this to, say you're trying to write a really, really important variant. You're typing and you're typing and you're like, oh man, I don't know if that word's spelled right. I'm the worst speller. I have some students out in the audience, they know that I'm the worst speller. So what do? You can yell at me if you want.
Spell check.
Spell check, yes. You always go to spell check, you find those mistakes and you fix them. So when viruses are replicating their genomes, most viruses don't have a way to spell check. So they just introduce mutations all over the place. One of the nice things about coronaviruses, which has actually made this list shorter than it could have been if it was flu, for instance, is that coronaviruses actually do have enzymes that go back and do spell check. They're like, hey guys, we made a mistake right here. Let's get rid of that mistake and replace it with the right thing. So I will say, the good news is that we have less variants than we would if it was a different type of virus. However, we do have all of these variants listed up here, and they're continually arising every day. So we have all of these different variants. You can see we now have 3 different Delta variants, which is the one you've heard the most about. Alpha was kind of the starting one. And you can see that in terms of fitness, so that means which virus is out there making everybody sick, Delta is clearly in the lead, right? Interestingly, we also have Mu up here. And because Delta was so good at transmission, it actually kind of protected us from Mu, okay? So Mu was actually going to be kind of like the next threat. And Delta came along and was like, I transmit way, way better than everybody else, and just kind of blew away the competition. So if you're like thinking about being at a track meet and you have that one person who's just like super, super fast and just like blows away the competition that's way out ahead, that's Delta. So we have to, when we're thinking about this and having people protected against it, we have to think about these variants. Right now, we know that for the most part, the vaccines that are currently exist are protecting us from these different variants. Mu, we were concerned about, but Delta blew it out of the water, so we didn't have a lot of breakthrough cases due to Mu because Delta infected everyone, right? So Mu was just squashed out. Okay, so this is something that's continually being a concern, is that the longer we keep this going, the more of these different variants will appear. Okay, so that leads us to this idea of, is it going to be a seasonal type of thing? And lots of epidemics are seasonal. So we have two examples of flus on the graph where you can see that basically in the winter months, we get flu. In the summer months, it goes away. Okay, and that's true over, so this is the 1918 pandemic, and then this is the 2009-2010 swine flu. Okay, so you can see that they're seasonal. When it's cold outside, we get it. You might be thinking, but what makes the virus seasonal? Mostly it's us. Our human behavior is what makes it seasonal. So we've seen this a little bit with COVID as well, where in the cold months, when everybody huddles indoors, we see spikes. In the warm months, when everybody goes outside and is spread out more, the cases go down. So that's actually shown on this graph, where we have in the winter last year, we're going into the summer, and now we're kind of going into the fall of the year. And this is the Delta outbreak over here. So the good news is that we had this very large spike last time. This time, we're kind of on the way down, and we didn't go as high as that one, and not as long as that wave. So our waves are getting shorter and lower in magnitude. So we're getting less infected, and we're wrapping it up faster. So why do you think that is? Partly because of vaccinations, and it's partly because so many people have already had it. So our immunity is going to shrink the duration of that wave. It's also going to shrink the magnitude, because as you have people who are protected, you can't, and you can only infect so many people, and our immune systems are winning, so the magnitude's going down. Okay. As we allow the virus to continue replicating in unvaccinated people, it's going to make more mutations, and we're going to see, just like with flu, occasionally we're going to get one that we don't have immunity to anymore, and you're going to see something like this. So this is why, me and Dr. Slee are over here like, hey guys, please get vaccinated, because we don't want this to happen again. Nobody wants to go back to being stuck in the house for 4 months. Actually, I kind of loved it, but nobody else, all those extroverts, really don't want to be stuck in the house for another 4 months. So vaccination is really our best protection. Okay, so even though we're kind of seeing this, trend in good news in our country, we do want to not let our guard down. Even though the numbers are low, we don't want to relax our mask mandates. We don't want to start, going to large gatherings without masking. We want to really stay vigilant. And so we want to get our COVID vaccine. We want to get our flu vaccine. All the vaccines, just go. We need all the protection we can get to keep us in the room, not at home. Okay, we have some questions. I'm gonna come sit down. Go ahead.
So what we'll do here is I have some questions that were submitted to us a little bit earlier, and we'll kind of pose those with Faith, and we will open it to the audience on Zoom and in the room. Okay. So Faith, are you with us?
I'm here. Can you hear me?
Yep, we can hear you. So Faith, the first question is for you. Is it true that if I had COVID in the past, I do not need the vaccine now?
So we actually get this question a lot, and interestingly enough, across healthcare workers across the entire United States, and including the health system that I work at within UPMC, a lot of our vaccine hesitancy is due to people who have had the vaccine and are choosing to not get vaccinated after they've had COVID infections. However, what we are seeing is people who have had natural, had the disease, had COVID-19, are then now developing COVID-19 again, because the immunity that you get from the vaccine is much more potent, much more stronger than what it is with the natural disease process. And so we're seeing people having secondary, and actually we've had some patients with tertiary COVID-19. And unfortunately, due to the variants that Dia explained and talked about, they're coming in sicker than their original disease. So somebody that we had, a young 41-year-old mother with a 13-year-old and a 9-year-old, had COVID-19 last fall, chose not to get vaccinated because she already had the disease. Came in this time, unfortunately, into the ICU on the ventilator. She has survived, however, is still extremely ill and is now living in a long-term acute care facility. So, a lot of people think that, the natural immunity is great, but unfortunately, due to the variants, it's not. So we do recommend that people do get vaccinated, even if they've had the disease.
Thank you, Faith. That's really important, I think, because you hear in the media now that natural immunity is just as good as the vaccine, and what you're seeing is it's clearly not.
No.
Let's pass Faith another question. So the death rate for my age group is pretty low. This isn't from me, by the way. Why should I get the vaccine?
So this is another question, especially within healthcare workers. And we, living in Pittsburgh, we have a very large university crowd. So we have a lot of universities in our area. So we have a lot of people in a younger age group. But we also are one of the oldest in the country too. And that's why it's so important that the younger get vaccinated. What we're seeing is people are not getting vaccinated. They're getting COVID. They're going to a party, and then they are giving COVID to their loved ones. We've had many occurrences where there's a wedding and the father of the bride got COVID because somebody younger who was unvaccinated was there and gave it to him. And he was unvaccinated at the time also, that ended up subsequently dying. And so for anything, it's the greater good of the world for you to get vaccinated so that you can decrease the spread. We know that if you get COVID, once you've been vaccinated, the time where you're shedding virus is much less and less potent, and it has less transmissibility if you're vaccinated than if you're not. And so to protect your loved ones, to protect your family members, to protect the world, even if you're young and there's not a high death rate in your area, you're doing your due diligence and saving others.
I think I'll want the next question to you as well, which also wasn't from me. Will the vaccine prevent my ability to get pregnant?
I'm glad you didn't submit that question. Actually, I had this conversation today with somebody who has been struggling with pregnancy, and she's going through infertility treatments, and she is now being mandated by her workplace to get the vaccine. And it's scaring her because, everything that she hears in social media and everything that she hears from family and friends. And so I had a long conversation with her, and it does not decrease your ability to get pregnant. It has no effect on your ability to get pregnant. It's not dangerous to you when you are pregnant. We actually recommend vaccines to pregnant women. We want you to get vaccines. It's just like the pertussis vaccine. We used to give it to women after they had their baby, but now we give it to you in your second trimester, because once you get the pertussis vaccine while pregnant, the antibodies actually go to the baby via the placenta. And when they're born now, they have immunity to pertussis and help prevent whooping cough. And so same thing with COVID-19, the flu shot, any vaccination, pregnancy is okay, and it will not prevent pregnancy.
Can I add something?
Absolutely. Go ahead.
I'm going to just add to that. So I've had multiple conversations with people who have this concern. And it took several people before I was able to figure out what the actual concern was. So what it was, they thought was scientifically behind what was causing infertility. And what it was is the spike protein on the surface of the coronavirus, what it does is it fuses the virus membrane with our cells. So what it does is it fuses two membranes together. There is a protein in the placenta that has a very similar function where it fuses cells together. That protein is called syncytin 1. So people were thinking these two proteins, because they're so functionally similar, they do the same thing. They thought that the antibodies that we produce against spike would cross-react and destroy the syncytin 1 protein, which if in effect would destroy the placenta. That is absolutely not the case. People have done numerous studies where they've shown that those proteins look nothing alike. Just because they're functionally similar doesn't mean that they're going to be recognized by our immune system the same way. So that's kind of the science behind that. And basically what happened was you had somebody who wasn't a scientist. They found two proteins. They're like, oh yeah, these are basically the same thing, so it's going to target it. And they never followed through because they hadn't had the scientific training to follow through on that thought process and actually look at whether our antibodies in our body would actually recognize that thing. They just thought if they have the same function, it's going to target both of them. And that's absolutely not the case. So that's kind of the scientific basis of that claim and how that is just not true.
And Dia, I think it's interesting to point out that one scientific person who kind of looked at something and made an assumption has then put the whole world standing on their head with a rumor that then goes around and then gets twisted and mangled. And then now everybody has this fear just because of somebody who didn't have a clear understanding. And that's why I'm glad we're here to dispel these myths.
And along that same line, I think another part of that argument was it is true that after many vaccines, women's menstrual cycles may be slightly altered. So your period may come a little later than normal, and that's not all that uncommon with vaccines or stress in general. So that has been used to say that it could cause fertility issues there, when it's really just a product of biology.
And the person that I was speaking to today that had concerns, she kind of went into the functionality of with vaccines, you have an inflammatory response, right? So your body has an inflammatory response to the vaccine, but your body will have that inflammatory response if you get COVID worse, and your body will have that inflammatory response if you get any other viral disease or bacterial disease, or like you said, any kind of stress. And so, putting all of your eggs in the basket on a vaccine that actually can save you and hundreds of thousands of other people for one cause doesn't really make sense. So.
And we'll ask Faith one more question, and then there's no questions in the chat. So if you're online, please do enter those in the chat, and then we'll look at the audience for some questions. Faith, so you are on the front lines here. How are healthcare workers doing? So obviously we're concerned about our future nurses and PAs and those that are going out into the community. How are you guys doing, and how are you handling this?
I kind of start with my experience and being charged with the response at my hospital. I'll never forget that on March 13th of last year, when the World Health Organization declared COVID-19 a pandemic, I looked at my husband. We got this call from the school saying that was the last day the kids were going to be in school, and the following week, that everything would they'd be home and virtual. And I looked at my husband and I said, you know what, this is going to be 3 months. It's going to be a 3-month inconvenience. We have a great response. The country will pull together. We will come together with a plan. It'll be back to normal in 3 months. And it's 20 months later, and it's not back to normal. We have little periods with these peaks and values with admissions in the hospital. And we get so excited when we get down to less than 5 patients. And then we bounce back up to 20, 24, 30. And it's no longer the fear of caring for the patients. It's now the emotional toll that it takes on the staff and caring for the patients. Most of our patients that are hospitalized are unvaccinated. They're extremely sick, and it's not just the acute period of the disease. It's a long-term disease. There's people that are a year out from getting COVID-19 that still have no smell and no taste. And they're now suffering malnutrition because they don't want to eat because nothing tastes good to them. We have people that are still suffering pulmonary embolism and blood clots, myocarditis, pericarditis. People are going on disability who were in their 40s, 50s, and 60s who were previously healthy before the disease. So, having the patients come into the healthcare system who weren't vaccinated is an emotional toll for the staff, because we know that a lot of it could have been prevented. And it's really hard when you know that something's preventable. And so, and then helping families through these times is also very emotionally hard, because the families are now questioning their decisions and what they decided to do and not do throughout the process. Go to this party with grandma for her 93rd birthday, was going to be her last, and turned out it was going to be her last because she got COVID at it. It's the emotional toll that the families and caregivers then bring in with them while we're caring for them has just also become so hard. The flu season, at most, you get a handful of patients that are really sick. And that's because, the flu shots are ingrained. We all get flu shots. That's what we do. And that's not the case now with COVID. And it's hard. And so we have a lot of healthcare workers who are leaving healthcare because of it. And a lot of them are baby boomers and are at the period where they can leave because they have their retirement funds padded and it's time to go. But unfortunately, there's not a group of people to follow them in. 2020 was supposed to be the year of the nurse. Florence Nightingale dubbed 2020 to be the year of the nurse. And if she would have only known what the nurses were going to go through in 2020, I don't know if she would have picked 2020 to be that, because it's been rough. It's been difficult, and we're waiting for that downhill slope again. That's where we're at now. So out here doing lots of talks on vaccination. We just had our COVID-19 first booster clinic at work. We vaccinated 239 healthcare workers with the booster yesterday at our hospital, 1,400. We have tomorrow and Saturday. I'm getting my booster tomorrow. I'm super excited about it. Coming this week. And then flu shots. We've had record flu shot immunizations this year, which is so exciting because we just, we want to keep the healthcare workers, keep everybody healthy and keep them not in the hospital. That's the goal.
We'd like to turn it over to the audience. Any in-person questions? We have a microphone to pass around so everybody can hear you. Press and hold.
With the new variants, is the booster going to be any different than what we received? I had Moderna, I had 2. Is the booster going to be any different? Are they looking at a different booster, or maybe later on?
At this point in time, the boosters are the same. The only difference thus far is Moderna is actually half the dose as the first 2. So the boosters will be the same. And the theory, I think, behind that is they're showing good protection against the current variants that we have now. But there's always that potential that a variant could emerge that would sidestep the vaccines.
And just to follow up, if you get a booster, is the length of time you have protection longer than when you had the first 2 shots of Moderna?
So the available data that we have now suggests that, but again, we only know as far out as we've looked. So who knows how long it would be, but the more you're exposed to something, generally the longer and the more robust your immunity is.
Thank you.
What can you guys, I'm sure all of you have takes on this, what can you tell us about the current state of our understanding of chronic health effects, long COVID as they call it? I think Faith talked a little bit about this, people still losing their sense of smell, but you know, I've heard certainly lots of stories of other symptoms. Where's the research on this? What do we know, and what do we hope to collect over the next couple of years?
Faith, do you want to address that one?
I can only tell you, I don't know statistics, I don't know data. I can tell you what I've seen. And what we're seeing is people who, I mean, right now, for instance, the amount of people that are flooding the emergency departments are people who have had COVID in the past year and are now having additional healthcare needs because of their disease. Continued shortness of breath. Like I said, the blood clots are really frequent. That's something we discovered early on when this all started with our first patients that we had in our ICU back in March of last year. We realized how many of them were getting blood clots. And it makes sense because it's part of the inflammatory response when you have an infection. And so right away, we started treating them with treatment dose anticoagulants to prevent them from developing blood clots. So we continue to see that. And what we do continue to see, which is really interesting, that's not in the news anywhere and not really a popular conversation, are patients that are elderly ended up with a lot of dysphagia, difficulty swallowing. And because of the difficulty swallowing, they were getting aspiration pneumonia. And they were also having difficulty eating and having issues with malnourishment. And we're continuing to see that for patients coming in. I just had a 65-year-old yesterday who's not even elderly, but he came in with continued bilateral upper extremity weakness and difficulty swallowing. And those were symptoms that he had during his COVID disease. So I don't have statistics and numbers, but I can tell you what we see is infections of last year still returning this year with continued symptoms.
Hey, thank you so much for answering these questions. And this doing a great job. I'm still struggling a little bit on assuming no variants. I'm struggling with natural active immunity. We've always felt was a better immune response than a vaccine. And I've not dealt with infectious disease physicians specific with COVID, but for years we've always talked about, I had measles, I had chicken pox, I'm not worried about getting measles. Again, assuming no variants, I'm really struggling why, if somebody has had the Delta variant, that is not a better or as good anyway in terms of maintaining an immune response for this particular virus. Tia, is there some molecular reason? Is there something that I'm missing in terms of, and could that be a reason why, even when we see now people going in pretty crowded areas, and we know a fair number of unvaccinated, we're not seeing the rise that we were expecting? Is that due to some, again, form of natural active immunity that's going on that they probably could have had and been asymptomatic? You know, people have caught coronavirus have been asymptomatic, even in the age group we're seeing in universities. So I'm just trying to get a handle on why. Because if you look at our own population, maybe this is two questions, sorry. If we say 70%, let's hypothetically say, are vaccinated, what percentage would you put that probably have a natural active immunity? What percentage of those? Would that be another 10%, 20%? That they may not even know they have natural immunity. So if we say, you know, you have 70% known vaccinated, theoretically, is it really 80 or 85% that have some form of immunity? That's my question. Thanks.
So I'll address the last part, you can address the first part. So I think we're starting to recognize that. So there was a question or a statement in the chat, both LVHN and St. Luke's now will allow proof of natural immunity instead of vaccination. There are some caveats to that, but that is true. So I think we're starting to realize that natural immunity after an infection is there. The problem is that COVID seems to be different than other pathogens. So with COVID, you can have somebody who has it, but then have a very low antibody titer as a result.
Yep.
And Dia may know more, but I don't think we've uncovered that mystery yet. Particularly in those that are asymptomatic or not relatively sick, they don't seem to have long-term immunity after that.
Correct.
So related to that, what we do know is in terms of asymptomatic, a lot of them are keeping the infection kind of up in their nasal areas. And in general, we don't produce strong immunity to things that are kept kind of up in our nose. So in general, my guess is asymptomatic people do not have protective immunity. And if they do, it's not lasting. So the other thing that happens is viruses are really, really good at evading the immune response. So the viruses are actively trying to prevent us from producing long-term immunity against it. And we don't know all the details of what's causing it, but we do know that coronaviruses really, really disrupt your immune system. So they're preventing innate immunity. And then they're just inducing tons and tons and tons of inflammation, which is actually causing a lot of the damage to people's lungs.
Yes.
Is this dysregulated activation of inflammation.
And I just wanted to pop in also and comment regarding Moderna has done some really fantastic studies. And then UPMC has also done some fantastic studies looking at antibodies after vaccination. And what we found with natural disease, it's about a 90-day window when the antibodies really start dropping and if are non-present at all, where with the vaccination, specifically to Moderna, and that's why they've come out with the recommendations of the 6 to 7 months, that's when they're starting to see the antibody load drop off also. So you're going from a 90-day window to a 6 to 7 month window, and that's proven through these studies and why we're recommending the boosters now.
Thank you so much. This is a wonderful slam dunk presentation by scientists here. I guess my comment is I think you just made an excellent rational proof that the vaccine should be mandated.
Is that a question? That's certainly one avenue. So it's hard. There's a lot of things that play into that decision as well. But I think that's why we see more and more mandates popping up. And I think I'm one of the people that believes there should always be exceptions to mandates too. I don't want to be the person to force somebody to do something they don't want to do. And we also have to have medical exceptions for people that just can't get the vaccine. So I think mandates with exceptions are probably the way to go. But that's just my personal opinion.
We have actually had flu shot mandates within healthcare workers since 2015. And it's funny because as healthcare workers are upset about a possible mandate with the COVID-19 vaccine, I have to remind them that they've had to have, I've had 20 years of flu shots. And I have to remind them of that. And so I think children are mandated to get vaccines to go into schools. But there's always exceptions, like you said. So I think that's important. There is a question in the chat, and I don't know if we addressed it on when they anticipate children under 18 being able to get the vaccine because it's been put off due to the side effects.
Yeah, so I do see that. I think the question was related to, can somebody comment on the side effects and the risk versus reward there for those under 18?
Yeah. So I think the risk versus the non-risk is what we've been seeing. And that's why they've been doing the research and the studies on volumes and doses for the children. They were seeing myocarditis with kids getting the vaccine in the trials. But the risk of myocarditis with natural immunity is worse. So as we continue to look at what the appropriate dosing is for kids. And I think they're almost there. I keep hearing within the month, we're going to have the dose that's available for kids coming out soon. So I'm hoping that it is, because I have an 8-year-old and 10-year-old that I can't wait to get vaccinated.
I believe the date is November 2nd for kids, for Pfizer. Not that I'm counting. We'll come back to the in-person for 1 second. There's another question on here Can you speak to preventative options and early treatment options besides the vaccine?
Can I address that one real quick?
Absolutely.
All right, so thank you. I have to tell you, one of my frustrations and one of the reasons why I hear a lot of people not wanting to get vaccinated is because they hear that there's so many treatment options out there for COVID. You can go to the hospital and get monoclonal antibodies. You can go to the hospital and get hydroxychloroquine, Decadron, remdesivir, the new drug that Merck is coming out with next week. There's all these treatment options, and I don't want to get the vaccine because I don't know what's going to do to me. Well, we don't know what any of those other treatments are going to do to you either. So putting your decision in that, I'm not really sure how that works out. But right now, the government has regulated the majority of the treatment options that we have available. So our supply chain has been damaged so severely throughout the United States. And I know many of you know that when you go to the grocery store and can't get Gatorade right now because the supply chain has been broken. We can't get crutches or walkers because of supply chain. Well, that's the same thing with medications and drugs. So right now, the government has taken over the regulation of distribution for most of the treatments for COVID-19. And I never know day to day if I'm going to have enough to be able to give the patients that come in the door. And unfortunately, right now, we do not have the ability to give people monoclonals every day. We don't have the ability to give a lot of the other medications either. So yes, there are treatments, but they're not a guarantee at the facility that you go to, depending on the volume and how many patients are currently receiving them, and if the government has even actually distributed it to your facility or not. So get the vaccine, it's available.
And along those lines, I think the early preventative strategies, masking, social distancing, hygiene, all those things that Dr. Beachboard talked to with the Swiss cheese model. And I think those are the things that we have that are guarantees to work.
Yep.
So I think that's where we have to invest. And of course, the vaccines. Let's go back in person, right?
I have a question for those of you that have kind of more like frontline experience with COVID in the field. And is that, do you have any specific like stories from your own personal experience of what you've seen this virus do and the consequences you've seen for people that have contracted it that you might be able to share with those who are still debating or hesitating when it comes to getting the vaccine?
Yes, I'll never forget our first patient that required intubation that came to our hospital, and that was in April of 2020. I went down to the emergency department because he was going to be the first person to be intubated. And one of the things that we call COVID patients are happy hypoxics. His oxygen saturation was in the low 60s, but he wasn't struggling to breathe. He was just sitting there, but he had this zoned look that wasn't normal. And so we knew at that point he had to be intubated, and it was our first intubation. So I was there to make sure that everybody was wearing the appropriate PPE, that everybody there was protected, and that we did everything right for the patient and protecting him and getting him cared for. And, from that point forward, when the patients are in the ICU, we're doing something called proning them. And so the best ability for them to breathe is to actually be flipped over onto their bellies. And so we do periods of proning and to help with their lungs and help get their lungs to heal. High doses of medications and drugs, and they're put into comas. They're developing hospital-acquired infections. They're developing hospital-acquired pressure injuries because of how severe their illness is, the malnourishment that's coming with it. And then the long-term effects that comes from it once they're discharged, continued rehab, inability to work, and complete disruption to their lives. So more often than not, and that's the sickest of the sick that come in that survive. The other end of it is those who don't make it out and pass. And many of them make it past the non-infectious period, which is great, but the isolation of it all has probably been the worst. We limit visitors, we limit family members, we limit because we don't want to have spread to other patients that are there that don't have COVID. We want to protect our healthcare workers. And so the isolation is so severe for the patients while they're with us. And then when they go to post-acute care facilities like skilled nursing facilities and rehab facilities, but the isolation for the staff is just as hard because they're working in these COVID units and they're in full PPE, and the only people that they have to communicate with are the patients and minimal other people. And the isolation has been probably one of the most difficult things for the caregivers, the patients, and the family, and the hospital workers.
So let's go to a question online. So someone said the COVID vaccine is very different from the flu vaccine and other vaccines. The mRNA technology has not been studied long term. That is the concern for many hesitant people. Can someone speak to that?
Not to be flippant, but literally, I'm sure there were people who thought that about the smallpox vaccine whenever it was the first vaccine that was invented. And now we have eradicated smallpox. So just because something is new doesn't mean that we shouldn't try it. In general, yes, we have not had mRNA vaccines broadly used in the past. This is not the first, like the idea for mRNA vaccines did not occur to people 18 months ago. This is something that was in process. Moderna built their company based on the idea of making mRNA vaccines. And that was before the pandemic started. So they had been working in other virus systems and they had perfected the technology. And as soon as SARS-CoV-2 came about, so that's the virus that causes COVID-19, they just swapped out what they were working on for the SARS-2 spike protein. They knew they should use a SARS-2 spike protein because coronavirologists have been working on this for the last 20 years, almost. Since the SARS-1 outbreak of 2003, we have been working to determine what proteins are going to give us the best antibodies. So they knew spike was going to be the target. They can simply put it in. It happens so fast because the technology is actually very simple. You synthesize nucleic acids. That can be done very quickly. If I wanted to literally order the DNA sequence for spike protein, I would have it, okay, we'll not say right now because of all of the shipping problems, but if this was not due to the shipping problems, I could get it in 2 weeks. When MERS emerged in 2013, we had the entire genome in our lab in less than a month. We just did. We ordered the 30,000 base pairs so that we could generate that virus from DNA that we converted into RNA in less than a month. The technology is just fast. We can do it rapidly. So I think it's wonderful personally. And I'm looking forward to, as new things emerge, we can just pop out the thing that produces good antibodies and put it into these mRNA vaccines and deliver them rapidly. So I think it's actually an amazing technology. And I really look forward to seeing more vaccines designed that way.
And I think the other important distinguishing point to make is there are multiple types of vaccines. mRNA are one of them. Historically, the vast majority of side effects from vaccines occur within 2 months of receiving them. So there has, I hesitate to say never, but there has never been a case of a vaccine causing harm after that 2-month window. I never say never in biology, but that is really the norm, is that we don't just see 2 months or 2 years from now something popping up. It's just not the norm of vaccinations. And although mRNA is a newer technology, I don't see why it would be any different than our other methods of vaccination. Tom?
So Johnson & Johnson vaccine is shown to be less effective, but it has better logistics. It's only one shot. A lot of people, if they do get the first shot with the Pfizer and Moderna, they don't typically come back to get the second shot because they didn't feel well. But I've been kind of curious, if you only got one Pfizer or Moderna shot, would it be more effective than even a single Johnson & Johnson shot? Or have they looked into the effectiveness of a single Pfizer or a single Moderna shot?
I know they've looked into it, but I don't know the data off the top of my head. Do any of you ladies know it?
I am I'm like racking my brain for graphs and I don't know what that data looks like, but there are lots of people who have gotten a single shot. I will tell you anecdotally, I had a friend who had the first shot. She was sick, so she couldn't get the second shot. She wound up with COVID. And they said the only reason why she did not die was because she had had that first shot. So I do think that I do not recommend only getting one dose, but I do think that they are protected. I cannot give you the data in comparison to the J&J vaccine specifically.
And I don't have data, but all my stories are anecdotal, and especially from the nursing home population, because that's the population that was targeted first. There was many outbreaks happening, as you guys know, in nursing facilities across the country, and we were getting those first doses into the arms of those patients as quickly as we could, but outbreaks were still occurring, and they were getting infected before their second doses. But their admissions to the hospital were low-level oxygen. They weren't requiring intubation. They weren't requiring long hospitalization stays. So they were much better. That was much better the second time around than the first time around, where they were all just unfortunately passing.
Right?
You had talked earlier about masking in schools and how much that's helping the data. There's a lot of people that will say that they're worried about the long-term effects of masking. It was not safe for kids to be breathing all day. Do you have any data on that to talk about that?
Want me to take it? I'll take it.
Sure.
So what we've seen thus far is that there really are no negative impacts of wearing a mask for that long. Surgeons have been doing it for decades and nobody's cared. The area that I think is for concern is in younger children and social development. So there is some evidence that they miss some of those social cues. The only study that I've seen that actually looked at it pretty well suggests that masking does kind of hinder a child's ability to pick up on social cues. So is somebody smiling or happy or sad at me? But the good news is when you take the masks off, there's a washout period and those emotions and pickups come back. So there is no concern health-wise. They're not breathing in anything that's inappropriate. That's all been disproven. They're getting enough oxygen. That's not a concern. You often hear that they're sucking in their own germs. Well, they're their own germs. They have them to begin with. So I think no one wants the children to be masked forever. I personally don't. But I think where we are right now, until we can get them vaccinated, it's the best thing we have. But I think the concerns are a little overblown in terms of that. But I will acknowledge that I am concerned, particularly for my son. I have a 7-year-old. Is he developing socially as he should? I think so, but I am concerned that there could be some impacts. But as far as I know, I don't think we've looked at it in a scientific manner yet.
Agreed.
So we have a question from the chat here. It says vaccination and masking is important, but why is there not more talk about people losing weight, quitting smoking, exercising, and taking vitamins? Would this not help a person's immune system to better fight off COVID?
I agree with you on that one. We do know that vitamin D is extremely important with the COVID disease process. And what we know is it doesn't help once you develop COVID, but it helps you prior to getting COVID. So I've been taking vitamin D since March. Every day I get my vitamin D because I know in Pittsburgh, we don't have enough sunshine and I do not get enough natural vitamin D. But the losing weight, it's definitely a major factor. Our bariatric patients, our patients with BMIs greater than 40, are definitely have a much more difficult time. In addition to the ones who smoke, diabetic, hypertensive. And so I agree. I think there's too much focus on social media and focus through the media on the division that is being created about the different aspects of COVID and hasn't taken the information that needs to be put out there, which is increasing and improving lifestyles to help fight it. So I'm 100% on the bandwagon with you.
I think we'll end on one question here. Are there any questions in the audience? We'll get everybody. The last one here I think is worth kind of thinking about as a closing question. If vaccine hesitancy and politicization continues, are we stuck dealing with this for years to come? Beyond masking my family, being vaccinated, and anxiously awaiting a vaccine for my 6-year-old and my 1-year-old, it's hard to figure out what, if anything, I can do to help get us out of this. But that would be a nice closing question. Faith, I think that one kind of sets you up. Are you there, Faith? Oh,
Faith, you're muted.
you're muted, Faith, somehow you got muted.
Sorry, I was trying to tell my kids to turn down the TV upstairs. Could you repeat it real quick? I'm sorry.
Oh, sorry. So basically, I thought it would be one question I thought was a good closing question. Basically, to summarize, if the vaccine hesitancy and politicization continues, what can I do as an individual in this fight to help get us out of this while we wait for vaccines for kids and other treatments?
I think I've actually, as in depth as I am in everything in the hospital, I have not decreased my activity. 7, 8-year-old and 10-year-old. We went to Disney in February. We went to St. Martin. I mean, we've gone and lived our lives. However, the one constant that I always do with me and my children is masking. And so they know as soon as they get out of the car and we go into a grocery store, they have to have their mask on. Our school wasn't mandating masking in the beginning of the school year. They had to wear their masks. We wear masks everywhere that we're amongst people who we are not familiar with or know, to help decrease any possibility of asymptomatic spread from my children or myself or us getting the virus. So I think, the steadfast on masking is important and will help. You can continue to live your life until we can get to the point where, we get vaccinated, we get herd immunity, and we don't have the severity of the issues we continue to have. But that's opinion-based and science-based.
And I think that'll be the last word. Jackie's giving me the signal to cut it off.
No, I really appreciate Faith and Dr. Slee and Dr. Beachboard for joining us today. As we look to close today, I just want to say, do you guys have any final thoughts you could share? Something today that maybe we didn't cover that you would like our audience to know about the work that you're studying, or something you would like them to leave here with?
Get the vaccine. I think the biggest thing that I think most healthcare professionals are worried about now is the twin pandemic that could be coming of the flu season coupled with another potential spike in COVID. I think a lot of people have ignored the flu shot this year because of COVID. So I would encourage everybody to continue to get your flu shot and your COVID shot if you haven't done so already.
I'll just echo what he said. Like, vaccines are what's going to pull us out of this. I truly believe that. The science supports that. Definitely get the flu vaccine too, because we don't want, even whenever this thing started, the person that sat next to me at my job was a flu virologist, and we were like, what do you think it's going to be? And I'm like, it's going to be a coronavirus, and he was like, it's going to be a flu virus, because those are the two that we are always going to have to worry about. So we don't want to come out of a coronavirus pandemic into a flu pandemic. So please continue to get your flu shots, get your COVID vaccine. It helps.
My last words are be kind to each other, be kind to healthcare professionals, be kind to everyone. I have this terminology. It's called what do I call it? I forget now, but it's a COVID derangement syndrome is what I'm calling it. I feel like we've gone through this terrible period of 20 months of everybody just being angry and being mean to each other. And if we can get past being angry and mean, and get vaccinated and wear our masks and do what we need to do and be kind to each other and all of humanity, we can get out of this, and it'll make it a lot easier for everybody. So my end note is be kind. That's what we need to do.